I'd like to welcome Dr. Jeremy Moore and Jeanette Lynn back to present some of our interesting arrhythmia cases.
We're very impressed with the number of people who are braving it into the late Friday afternoon on this lovely warm day. So thank you all for hanging out with us to almost the end here. I have the privilege of working with Dr. Moore for this part of the symposium. We're going to be presenting to you some cases of actually fairly complex and interesting arrhythmias and management challenges in congenital heart disease. We will start with case 1. This woman comes to us. She's 22 years old, and she's in her 3rd trimester of pregnancy, so 29 weeks of gestation. Her past medical history, cardiac history, is notable for a bicuspid aortic valve, and she underwent the Ross procedure at age 9. Postoperatively, she did have some SVT, which was treated for amiodarone, but she was not continued on amiodarone long term. In her teens, she had some flip-flopping, as she describes it, for a few seconds, had a single episode of some symptomatic tachycardia in high school lasting about a minute, but nothing really sustained. However, over the past few years, couple years prior to her pregnancy, she did notice that her palpitations seemed to have increased in frequency. Now, within the last 2 months before her presentation to us now in her 3rd trimester, she's had increase in sustained palpitations, so not the flip-flopping, but the sustained palpitations. In her 2nd trimester, she had many episodes where she felt that her heart was racing. She got an event recorder, which recorded episodes of narrow complex tachycardia up to 250 beats per minute, which were associated with dizziness and dyspnea. Beta blocker was discussed with her, but given the low but not zero risk of potential intrauterine growth delay, she declined that and was started on digoxin. Early in her 3rd trimester, she awoke with chest pressure and dyspnea, and she presented and was admitted with telemetry showing episodes of SVT as well as non-sustained VTAC as well. She was observed for a while and then subsequently discharged when it seemed things were a little bit more calm, but 1 week after her discharge, she comes in with more palpitations. This is her past medical history, and her medications include digoxin, Procardia for suppression of premature contractions earlier in her pregnancy, prenatal vitamins. This is her exam. Normal thyroid function tests and electrolytes, and the echo showed normal biventricular function. She did have pulmonary stenosis with a peak rating of 30 millimeters of mercury and moderate pulmonary regurgitation. In addition, she had a mildly dilated neo-aortic root with mild to moderate neo-aortic regurgitation.
Okay, so this is the event monitor strip from one of her episodes. The referring cardiologist sent this over to us. And at this point, we had to make a decision about what to do. She had already declined further antiarrhythmics, and she was further along in her pregnancy. Anybody want to comment?
Jeremy, no 12 leads during the hospitalization of the EBCs of the TAC?
Not that we had at the time when she was readmitted, no.
Okay. I'm sorry, can you repeat the question? No, I was wondering if there were any 12-lead EKGs of the tachycardia during the hospitalization.
We didn't have anything sustained like this in patients. This is only captured by event monitor. Can you guys see? Yeah. So what we would proceed from here? Do you guys want to comment, or do you want to just keep going?
Well, that looks to me like SVT. The mechanism is far from clear. In this situation, one would guess that she had some kind of atrial tachycardia, most likely re-entry. But...
Okay, so we decided to pursue catheter ablation. Now, we knew she was pregnant, so we didn't want to expose her to any ionizing radiation. So we used a electro-anatomical mapping system to place catheters in the heart without fluoroscopy. We placed, looks like a duodeca catheter, the ablation catheter, and a catheter in the high right atrium for sensing purposes. And with atrial extra stimuli, not too aggressive really, so extra stimuli in the atrium, we're able to repetitively induce a non-sustained atrial tachycardia with a similar rate as her clinical tachycardia. The ablation catheter was moved during each one of these non-sustained episodes. The ablation catheter was moved to various sites within the right atrium, and at a site in the posterolateral RA, a very early signal was found. And again, this was non-sustained and irregular, consistent with the focal mechanism for the arrhythmia, and no diastolic potentials or diastolic signals were found during tachycardia. So this was thought to be a good site. This is just showing the signals, that these are good signals, basically. And so with non-sustained tachycardia and the ablation catheter at that site, we found electrical activation preceding the surface P wave by 50 milliseconds. And we decided to, at that point, decided to do an ablation, which was effective. This shows the electron anatomical map with the ablation lesions. There's also tags showing the electrical activation time, the local activation times. And with ablation, we saw acceleration of the atrial rhythm and then slowing to a sinus rhythm over just a few seconds. And with attempted reinduction, we couldn't induce anything in the atrium. So that was the sort of summary of the procedure.
When you reviewed the history, when amiodarone had controlled the tachycardia.
I'm sorry?
Amiodarone had suppressed the tach, right? And so why was it not considered to potentially, she's 29 weeks and amiodarone has been shown and we don't know the mechanism. So why was that not considered?
Mostly because of her desire not to be on other antiarrhythmics. She sort of basically refused. No,
the reason why I was asking is, if let's say that it was not ablatable or not something which you could get to, then what was, and let's say it was not successful, then what was going to be plan B?
Well, it probably would have been reinforcement of the need for antiarrhythmics at that point, I'm sure.
So Kevin, as your choice, what would
can you speak into the microphone?
For a 29-weeker, and for someone who's not as good as ablating without fluoro, or you don't know the mechanism, or you may even, let's say you may think it's a left-sided pathway, then what would be your antiarrhythmics you would use?
Well, that gets to what drugs can you use in pregnancy, and there's several that we know are relatively safe, or we believe are relatively safe, including amiodarone, flecainide, and sotalol. And so, those are also the drugs we use a lot for fetal supraventricular tachycardia, so there's a lot of experience with those medicines in pregnancy, and I would choose one of those three, assuming, of course, that digoxin failed. That's another drug we have a lot of experience with. Beta blockers are an option. They are associated with intrauterine growth retardation, and, I think I know who this is, and she had looked up on the internet. She was clever enough to get pregnant without talking to her doctor about it. But then became compulsively concerned about her own medical care and had looked up on the internet every potential side effect of all the antiarrhythmic drugs that you could take, and was very concerned about what they might do to the baby. And that, I think, was the primary reason she would much rather have a procedure on herself than expose her child to a medication. I think that's the sort of two-edged sword of the internet. But if you really look at those drugs, they are very safe with a lot of experience. Even with that admonition, I think this patient was still disinclined to take medication. I'm not even sure that she was taking the digoxin.
The reason why I was asking about the EKG was if this was my patient, and the EKG sometimes would be helpful, even if this is an atrial tachycardia patient, and you get a 12-lead EKG, let's say a strip, if you're lucky, sometimes if you may not get it, but if you get it, it may help in knowing what the P wave looks like and where it's coming from. And, I would probably have gone and done an ablation if it was a right-sided atrial tach. And if it was something else, possibly not, because I'm not comfortable doing a transeptal without fluoro. How about you?
Well, we have done transeptals using just TE guidance, and I think that is a option. We now actually can visualize the transeptal needle on the three-dimensional mapping systems, so that can also be used to do transeptals when you want to, kind of rigorously avoid fluoroscopy. Even when we do use fluoroscopy for transeptals, we now generally keep the fluoro times to under 3 minutes and quite frequently under 1 minute. So I'm not sure that there's a huge risk with modern fluoroscopy equipment to doing that even in the case of a fetus. So I'm not sure that I would need to know that this was right-sided in order to pursue a non-fluoroscopic ablation. The other thing that was remarkable about this woman is the non-sustained ventricular tachycardias. And we've actually now have some experience putting devices in using the non-fluoroscopic approach, both to map the atrium to find ideal sites for atrial leads and also to avoid fluoroscopy in pregnant women. We've had a couple of women present with sick sinus syndrome and profound bradycardia. And so even an ICD could be implanted in someone like this if they have significant risk of ventricular tachycardia. I presume that she wasn't felt to be at high risk.
No, she actually, well, we'll discuss her later course.
Okay.
But is it possible to do an ICD without any fluoroscopy, or you'd always use a little bit just to verify the lead?
I think in the modern era, if you do mapping and map the geometry of the ventricle, and you can see where the tip of your lead is, so you know where it is in the ventricle, I think you can avoid fluoroscopy altogether. The real question comes up: do you test the device? And I would say, based on the current data on testing the device, that this is a high-risk situation. The chances of it not working are really small. I wouldn't do any device testing. I would just implant it and leave it at that if I were to undertake that.
And I think to follow up on that, we don't do device testing in almost any patients who undergo ICDs for other reasons. So device testing is on its way out, just as a, where the field itself is going. Another point in a pregnant woman is, this often comes up from cardiologists, what happens to the fetus if the mother gets a shock? And fortunately, there is not a huge amount of data, but there's enough safety data to say that the fetus is not affected by a maternal shock. So that periodically comes up. So it's not just the implant, but if you have a spontaneous shock.
I think Jeremy, because a lot of the audience is cardiology, you might want to explain the steps of what is different between putting catheters with fluoro and without fluoro, and what are the steps that you take. And where all you need to put catheters, like how do you get into the coronary center?
Basically, you have to do it very carefully. But oftentimes you can get a feel for what, if the catheter goes up easily without any resistance at all, it's usually a good sign. The system we used in this case was Navix, which is able to visualize all the catheters as soon as you put them through the sheath. So we can see if they take a course into a side branch or not, and we can see if they're going up to the heart appropriately. And then once you get inside the heart, you see the electrical activity of the heart, so you know you're in the right place. And so it's not very challenging, really, to do. We do it for SVT. We do it for SVT routinely in the kids, so it's pretty routine now.
Last question. Internally, when you made the decision to perform this procedure, let's say you had a perf or something bad happened, then what would you have done? Let's say you needed to do a pericardiocentesis or something, then what is the backup plan?
Well, at that point, you do whatever you have to do.
Would you just use echo or ultrasound to get your needle in, or would you step on fluoro?
I would probably use the fluoro if the ultrasound wasn't readily available. I think the risk of fluoro, we actually, do fluoroscopic procedures in people who are pregnant from time to time, and the risk of the ionizing radiation is relatively small, but it's the ALARA principle, as low as reasonably achievable. But if, it was a question of saving this person's life or irradiating the fetus, I think having a live mother is a whole lot better than avoiding radiation, which would be sort of the same theory behind having an ICD. If the shock does probably have a very small risk to the fetus, the data is fairly limited on pregnant women with ICDs. There have certainly been some appropriate shocks delivered without any damage to the fetus. But I can tell you the VF the mother's having is a whole lot worse for the baby.
Dr. Giles?
I want to ask Kevin here, do you need to re-educate me or bring me up to date? The last I read, which is a while back, amiodarone was contraindicated.
It's a relative contraindication, but yeah, and it depends, I suppose, on the risk of the arrhythmia versus the risk to the baby. But you are correct. Amiodarone is not a drug that should be used in pregnancy. that they're
You
using.
said it's one of the three that was safe tonight.
But we do use it. But we do use it a lot for fetal tachycardia.
I
And
understand you may use it after you make a risk-benefit analysis, but just to say that it's safe and approved, I don't think that's the case.
I concur with Dr. Child, and Dr. Child was the one who taught the Arrhythmia Center, the adult EP program, that if you had to pick a drug and beta blockers don't work, sotalol perhaps has the very best data out there, even by FDA labeling.
So the Followup Holter, which was performed after her ablation, now she's at 35 and 4 weeks gestation. She's now having non-sustained ventricular tachycardia, which is what Dr. Shannon was referring to, up to 12-beat runs, which were more concerning. Because of that Holter result, we admitted her. And on telemetry, she had short runs of atrial tachycardia up to 8 beats, but also very frequent PVCs. At this point, she accepted having labetalol initiated. A repeat echocardiogram at this point in her pregnancy now reveals an increased pulmonary homograph gradient, now up to 76 millimeters of mercury, which is consistent with severe stenosis. And her neo-aortic regurgitation is now moderate plus. Based on the non-sustained VT and the concern about the risk to the mother, an amniocentesis was performed, which demonstrated adequate fetal lung maturity. She was induced and labored for 4 days, and then due to D cells, had an emergent forceps assisted delivery.
So I'd like to just bring up one point here that single plane fluoroscopy would be sufficient.
how good are your measurements? Normally you measure on the fluoro for, or as compared to echo to choose which size balloon, and how good is that?
Yeah. So that's a great question. I think if you visualize the convoluted well by echo, then you can size the balloon and start conservative.
Yeah.
But you can size the balloon according to just using ICE or even transthoracic echo. So I don't think necessarily doing the angiogram, making all the measurements out is necessary.
Why did the valve deteriorate so fast? Wasn't the gradient much less just a few weeks before that stage?
There are volume changes in pregnancy, and as she progresses with her volume, I think the volume is going to account for some of that stenosis, that increase in gradient.
Usually happens before that week. Usually your volume plateaued out by the late 20s to 30 weeks, although individuals can change. So your maximum change on the gradient should have been before that. But when was the first gradient done? I lost track of it. Oh, it could have changed in that area. That's a little more than I expected. Again, depending on how anxious she was, whether she came in dry one time and not dry the next, in terms of NPL and all this.
Well, I think we're assuming that great quality echo was done both times with an accurate measurement of estimation of the gradient, which, the homograph and cost analysis may not be the case at all.
So she tolerated the delivery otherwise well, and an echo was repeated at an outpatient follow-up approximately 2 weeks postpartum. And she has moderate plus new aortic valve regurgitation, moderate pulmonic stenosis, mild pulmonic regurgitation. So the gradients across that pulmonic valve did improve a little bit after the delivery and after her volume status improved a bit. There was initially consideration of a transcatheter pulmonary valve for her, but due to the progression of her neo-aortic regurgitation during her pregnancy and after the pregnancy, the decision was made instead to refer her for surgical valve replacements so that she could have both her aortic and pulmonary valves replaced. Her electrophysiologic history doesn't end there. She did have a repeat electrophysiology study 2 months after her surgery, which demonstrated still that she had inducible VT, and so she underwent ICD implantation at that time. Any other comments about this case?
What was the ventricular function after the child was delivered? And did you do a cardiac MRI with contrast enhancement post childbirth before ICD implant?
I don't remember. I don't think an MRI was done, no.
It's one of those big things in the field, which is, and what sort of VT did you induce? Was it polymorphic, monomorphic?
It was VF, actually.
VF.
Very easily inducible.
That made it easy. So,
Yeah, monomorphic VF. Very fast.
So we'll move on to our second case. This is a 27-year-old gentleman who is presenting with 2 weeks of palpitations, dyspnea, and fatigue. His congenital cardiac diagnosis is double outlet right ventricle, Tetralogy of Flow type, and a bicuspid aortic valve. His past surgical history is notable for a Tetralogy of Flow repair at 7 years of age and aortic valve replacement. At 11 years of age, he had complete heart block and underwent a pacemaker placement. At 21 years of age, he was operated on again with an aortic valve replacement with a mechanical valve and also resection of subaortic stenosis. This was his presenting EKG at the time that he presented with 2 weeks of palpitations and dyspnea on exertion.
Looks like a paced rhythm with sawtooth waves, likely typical flutter. That's my first diagnosis.
This is his
so the
past.
patient had some intrinsic conduction. You presented this as a complete heart block before.
It's complete heart block.
Okay.
So that's junctional rhythm unrelated to the flutter.
Past medical history, hepatitis C, as we mentioned earlier, not uncommon. His medications, warfarin for the prosthetic aortic valve and also digoxin. He underwent a TE, I believe, as part of a cardioversion procedure, and this demonstrated right atrial enlargement. He had moderately decreased biventricular function. He had a dilated right ventricular outflow tract and main pulmonary artery and severe pulmonary regurgitation.
Okay, so this is paste. This
So
is
the digoxin was for the function, not to block the
I believe it had been started for function. Yes. So this is the paste rhythm here, and this is after catheter placement and induction of actually this is with his tachycardia. I believe he actually came into the lab with tachycardia. You can see down here the cycle length of 226. And the intracardiac activation, which I actually can't see well from where I'm standing, but I remember thinking that this is looking like a counterclockwise circuit based on the activation sequence, which is sort of, proximal to distal in the duodeca catheter, which is around the tricuspid valve annulus. And that was consistent with the EKG finding that we had seen previously. But as we mapped the tachycardia, we saw something a little bit unusual. What you're looking at here is a map. This is a reconstruction of the geometric reconstruction of the right atrium. This is the SVC here, the IVC. The tricuspid valve annulus is right here. You can't see it very well in this particular view. And these blue dots represent areas of split potentials, usually corresponding to either some sort of linear scar, usually in this position, atriotomy scar. And then the color code is displayed up here. It basically tells you which way the electrical wavefront is traveling in the heart, such that so that right here, this is arbitrarily designated as early, red, and then yellow, green, blue, purple, in that sort of sequence is the direction of the electrical activity in the heart. So this is what we saw when we started mapping, and I'll go to the next one too. This is a different view here on the opposite side. So now we're looking from the septal surface of the right atrium, and you can see there's another area of early activation. So that's what we had. That's what we sort of, after a detailed map, that's what we had. Any thoughts?
You don't have a LAO view?
Actually, I do later, yes. I'll skip ahead. That's okay, that's the LAO view there.
So you have early activation on both sides of the tricuspid valve, which suggests that that's coming from the left side.
Versus potentially two circuits was what we were thinking at the time.
So what did the propagation map of this look like? Did you see a figure of 8 or?
Yeah, that's a good segue. So this is the propagation map. Let me see if I can. Not sure how to get it to play though. What do we do to get it to play?
Does it play though? The video didn't play.
It should have a link. I'm just not sure how to move this. Can we play this video?
So it's in that's from this too. So sometimes these propagation maps are looked at during a procedure, and they tend to be incredibly difficult in patients who have previous cardiac surgery, of course, because what we think looks like a re-entrant pathway sometimes is not re-entry. If you had a scar, a focal tachycardia may look like a re-entrant arrhythmia just based on where the sort of impulse starts from. So that's one of the reasons why he was going to show us the propagation map.
Will this play? Thanks.
There you go.
Okay.
So that's the
So that's is wonderful. So the next thing that would happen in a case like this more logically would be is what was your entrainment responses around the circuits? In other words, entrainment for the non-electrophysiologist is it's like what we say, if you are looking at a toy train going around a railway toy train track, if you were to put your finger on the train and make it move a little faster, you're controlling the circuit. So you could use pacing maneuvers to sort of probe what is important for the circuit and what is not. So that would be the next thing to do to try to find out which part of the circuit is critical and what would be the least amount of ablation that you can do to terminate this.
Okay, so this is the entrainment maps. The first site here, I don't know if you can see this, is between the anterior to the atriotomy, so between the atriotomy and the tricuspid valve annulus. And that was, so the pacing spike is seen here, and then we look at what we call the post-pacing interval, or the response to entrainment, and check to see how that compares to the tachycardia itself. And these were identical in that location, so very short post-pacing interval at that location. The second place we paced was behind the atriotomy, and at that site 2 there. And with that, we also had a very short post-pacing interval, a little bit longer than the tachycardia, but only 10 milliseconds, so still considered very short. We then paced from the distal part of the duodeca catheter, which was down in the low lateral right atrium. And there we had a longer return cycle length of, it was 250 versus 225, so 25 milliseconds longer, still probably close to the circuit, but a little bit further away. And then finally in the typical isthmus, where these oftentimes occur, or the critical areas of these tachycardia circuits usually occur, we had a long post-pacing interval, suggesting that it was not the dominant driver for this arrhythmia. So the atriotomy circuit appeared to be the key driver of this arrhythmia, although clearly it was going around the tricuspid valve annulus also. So we ended up doing, this is just a scar, this is a voltage map of the right atrial free wall. And you can see there's quite a bit of scar in this area and even more dense down by the IVC. This is healthy tissue up here. And then on the other side, there was an area of healthy tissue with scar posteriorly. We decided to take the approach of ablating between the atriotomy and the tricuspid valve annulus, and then connecting the tricuspid valve annulus with the IVC in order to interrupt both circuits. There's differences of opinion about where to ablate these, but that's what we chose to do in this case.
It doesn't matter as long as you're not injuring the phrenic nerve.
Yeah.
And what is done by Dr. Moore here is a very important step, which is to also look at the voltage map, because usually the story doesn't end with one tachycardia. It's after doing this you'll find that there are multiple other tachycardias that are induced. And this is a very nice demonstration of the lower scar that you see usually comes from cannulation sites, where, which is, again, this is what you see years after a surgical procedure, small atrial scars due to cannulation sites and also, atrial infarcts, I suppose, with stretch. Mm-hmm.
So the important thing here is, if you look at the surface EKG, and I said it's typical flutter, and the tendency is to sort of believe what is easy and simple and go after that. And if there wasn't a detailed map of the atriotomy and the scar, and one concentrated around the annulus, you could have made a map look like typical flutter, and you keep ablating and it doesn't terminate. So that's why in these patients who have, any four-chambered heart where there's an atriotomy, one has got to rule out this other arrhythmia. In fact, recently there was a publication in 2011 from Boston Children's where they looked at atrial flutter in patients with double outlet right ventricle and Tetralogy of Flow, and they had a very large recurrence rate when they only ablated the isthmus. So it makes a very good case in these patients to even think of, even if you've induced typical flutter, to find the atriotomy and take care of that part of the ablation too. So I don't think we're doing it very routinely, but I think for a complete procedure, that would probably be the thing to do.
Can I just ask you guys for the non-electrophysiologist looking at the surface EKG, and this may be very erroneous thinking on my part, but I would think that a scar flutter like what you were demonstrating would have a slower rate than the atrial rate that we're seeing here on this surface EKG. Could we be dealing with a typical flutter that is somehow not also propagating through that area of scar? Could we be dealing with the arrhythmia that you induced in the EP lab is different than this? Or is this just fast propagation despite all the scars that we're seeing?
It's a very insightful point. So if you look carefully at the 12 lead over there, in the precordial leads, there's barely a P wave that's generated by this. So to begin with, this is very atypical, which is true of any patient who's had a lot of AFib ablation procedures or a post-MACE or a post-congenital surgery patient. So the bets are off. Slower flutters typically are macro-reentrant. That is true because there's scar and slow conduction, or antiarrhythmic slow them down. But we've also seen the polar opposite. Sometimes you actually see flutters that are cycle lengths are even slightly shorter than 200 milliseconds, simply because it's now a sort of an iatrogenic substrate. Could this have been flutter and what we induced in the lab was different? If you looked at what Dr. Moore did, the second lesion that he placed is a very good insurance because a typical flutter circuit would have been terminated by that. So it's more or less like a very lateral flutter line. So that second lesion set that he put is a very good insurance policy against a typical flutter that can go around the tricuspid annulus because it connects two anatomic obstacles, IVC and tricuspid annulus in this case.
One thing I did mention was that after we did the first lesion, the tachycardia actually slowed a little bit. And I think what we saw was, so we ablated the atriotomy of the tricuspid valve annulus first. Then the tachycardia slowed, still had a similar activation to do a decapolar catheter. We didn't remap the whole tachycardia, but presumably that was the typical isthmus-dependent flutter at that point. And so we went ahead and ablated. And that's when actually it terminated, was with that set of lesions.
So where exactly can you point to where the first lesion was?
Yeah, unfortunately I don't have the pictures, but it was essentially right here.
Okay.
What we thought was the shortest distance between the two. Okay.
Jeremy, do you have the other image? You can put it up, the other case where there was a very small isthmus that actually adds to this?
Didn't copy it.
Oh, you didn't copy it?
Sorry.
Okay.
So about 7 months after he had his EP study, he underwent a pulmonary valve replacement with actually a mechanical pulmonary valve. That was a decision he and his mother made together as he was already on warfarin for the aortic valve. And after recovery, he did note improvement in overall energy level and activity tolerance as well. So a good outcome on both ends. Any other comments about that case? Okay. All right. We'll move on to our third case. Our third case is a patient with Tetralogy of Flow. So this is a woman who's now 62 years of age who presents with symptomatic sustained ventricular tachycardia, which required emergent cardioversion. Her past medical history is notable for a late repair at age 20. She underwent intracardiac repair in Mexico. At the age of 34 years, she underwent patch enlargement of the RVOT for subpulmonic stenosis. At age 53, she underwent pulmonary valve replacement with a 23 millimeter homograft due to severe pulmonary regurgitation, and also underwent a tricuspid valvuloplasty as well. They performed excision of the previously placed patch, extension of the ventriculotomy through the pulmonary annulus, and placed a new pulmonary homograft at the superior portion of the RV incision. Post-op, she did have junctional tachycardia and complete heart block, which subsequently resolved. At age 59, 3 years prior to her presentation now, she had increasing frequency of palpitations lasting 1 to 3 minutes in duration.
So it's very disconcerting QR, as it's consistent with the RV incisions actually. Shows, a significant portion of the RV myocardium is activated very late, which again, this is surface ECG marker of slowed conduction. Something we would be very worried about because it does have, the risk of sudden death in these patients is mechanical issues like, valve issues, and of course, scar, which only gets worse as you have further interventions. So, and of course, we had to comment on the atrial rhythm there.
Yeah, again, this is one of those things where I would ask for try and see whether I can get a EKG of sinus rhythm, because you can't rule out 2-to-1 flutter here.
So was this EKG after cardioversion?
Before.
Jeremy's not showing any easy EKGs.
Did I get the history wrong? She was shocked for VT, right? Emergently shocked
So
for VT.
we're going through her history here. She had what she comes in with now is sustained symptomatic VT, but she has a history of palpitation, so this is prior.
Okay, so that's a
Yeah.
prior EKG.
Yeah.
Right. So one would have predicted that she was going to have sustained VT from that prior EKG, but that was an atrial tachycardia.
The question.
So, Jeremy's question was, are we looking at predominant RV delay? And he was looking at the terminal forces in V5, V6. And, you would have expected to have seen a deeper S wave. But sometimes, that area is so scarred and it doesn't have enough myocardial mass to actually generate an ECG that's deep enough, or a S wave that's deep enough. But there is a component that is long enough in V5, V6. Which we've seen. We've seen this even in patients who've had, some forms of ARVC where even the inferior leads would show that. So it's fractionated depolarization of that region of the heart. Yeah, this is the kind of an ECG there's going to be a lot of work to be done in this heart electrically. So
she underwent a TE cardioversion after presenting with this EKG. Her echo showed normal LV function, mildly decreased RV systolic function, no significant conduit stenosis or regurgitation. She continued to have symptomatic palpitations and had documented recurrence of her atrial flutter. At age 61, then, she underwent ablation of multiple intraatrial rear entry tachycardia circuits, and post-procedure, again, had AV dissociation, junctional rhythm, which resolved, but ultimately she did require a dual-chamber pacemaker 2 months later for tachybrady. So we're getting close now to her presenting symptom now, which is palpitations, presyncope, and chest pain. And this is her EKG.
So what was the line of reasoning for them to implant a pacemaker at that time with that ECG? Was that done at that time when they...
We'll blame the outside hospital.
No.
Actually, I know the answer. She had a negative VT induction.
She had negative VT induction.
Yes, at the time of the ablation procedure for the intraatrial reentrant tachycardia, she had a negative VT induction, which probably speaks to the value of a negative EP study in someone with tetralogy of flow in that initial EKG. And the thing that was very worrisome about that first EKG, other than the atrial tachycardia, is when you see that kind of really low voltage of your right-sided forces in someone with tetralogy, then you have a lot of slowed conduction, a lot of injured tissue, and those are setups for ventricular arrhythmias. And even more than just a wide QRS, a wide low voltage QRS is very concerning.
That's like a 12 lead of a TET that looks like an ARVC.
Yes.
If you look at it, it's a TET. It just doesn't make sense. I agree with Kevin. It's a very disconcerting 12 lead.
Could I just make one point about that, if you don't mind, as far as the value of inducible VT in risk stratifying tetralogy patients? And now this has been looked at by multiple studies. Actually, Paul Carey has a very nice paper from a few years ago in Circulation looking at appropriate shocks and risk stratifying patients and coming up with a scoring system for that. And, inducible VT in the EP lab tends to carry a much lower risk than things like spontaneous non-sustained VT, elevated LVEDP, QRS duration, RV dysfunction, things of that sort. So it begs the question in this particular case whether, the choice should have been made to place an ICD, and it comes up all the time. It comes up all the time with us, despite the negative EP study for inducible VT, just based on risk factors for sudden death, knowing that patients are going to have, a fair amount of inappropriate shocks in this population. What do you guys think about that? Not actually relying on the EP study, but just relying on risk factors.
Well, I'll start off. I think it'll be nice to get comments from everyone. We don't completely go by EP study at all. It's just that if it's positive, it helps you. If it's negative, you still have to be like a Perloff, John Child kind of a cardiologist. Look at the 12-lead ECG. We do these procedures under sedation, and we talked about the value of the autonomic nervous system. So that could have a very powerful impact on inducibility of arrhythmias. So that goes to say, spontaneous arrhythmias have a greater value perhaps. You're looking at all the mechanical issues. And last but not the least, something that we are starting to do, and we have collected reasonable data on this in many substrates, is to obtain a contrast-enhanced MRI. And we can now actually safely do this in patients who have implanted devices. So this is something called the MagnaSafe registry, and we've started doing a whole lot of these studies under a special protocol at UCLA. So I think the characteristics of the scar and the location would also sort of factor in. And in the end, you're never going to have a prospective randomized type of data sets to make these decisions. So it requires a lot of team effort in doing so. And the way I look at that is the patient is anyway going to have a pacemaker. I'd rather give her the benefit of, even during the first implant, even if the induction was negative, I would say it's in my book, in our practice, it would be a class 2B indication for implanting a device that also has tachycardia therapies and not just a Brady device.
Yeah. Well, I think Jamil's point is a very good one. There is a long list of risk factors that you can look at, including LVEDP, which is a much more sensitive risk factor probably than a lot of things. QRS duration, even signal average EKG has been used, although I think that's a debatable thing, and I don't even think it was in Paul Carey's risk factors.
The other one, actually, Kevin, that I just want to get your opinions on is the value of, Jeanette talked about stress testing earlier and functional stress testing and PO2 max and things of that sort. But I've got to tell you, in this population, the thing that impresses me most is when people start having lots of PVCs, multiform PVCs with exercise, post-exercise, little short bursts of not sustained feedback. Anecdotally speaking, the people who have dropped dead in our practice have been ones that have had those kinds of stress tests and have not been protected. So I've been, in at least my practice, much more, you guys know because I refer these patients to you and say, we did a stress test and this is what happened. And so the question would be also, how about that, actually physically stressing people when they're awake to try to bring out arrhythmias, and how many PVCs is enough PVCs?
Well, I mean, obviously the jury's out on that, and a lot of efforts to use PVCs and complex ventricular arrhythmias and scoring systems for that have not been wholly successful in predicting risk. And it turns out the LV and diastolic pressure is a much better predictor of risk than any arrhythmia, any monitoring. But I would agree that certainly, if this woman had non-sustained VT documented prior to the placement of a device, that would have sold the ACHD probably. If I recall correctly, I don't think despite monitoring, she had none. And I think that actually probably predicts surviving her first episode of VT, which she did.
There's one recent paper that came out when it was talking about longitudinal LV dysfunction as a risk marker. Once they started talking those fancy echo terms, I fell asleep. But it's there. It's a recent Circ paper which shows that longitudinal LV dysfunction is an important risk factor. But a practical issue is, yes, we have all this. How are you going to justify an ICD placement? What is the indication you're going to write when you say in your report or when you're requesting an auth, and how are we going to do that?
But I think there has to be, this is one of those areas where I've often wondered when a transplant cardiologist asks us to implant an ICD, in the end, we make it a 2B indication. And I think this is when something is not known, when we've invested so much in a person's life, it would be, I would have a low threshold to actually do this. And, if you're already going to implant a pacemaker, I'm certain, we're yet to lose an insurance battle for authorization for implanting a device. And in the past decade, I remember even way back in year 2000, we were able to actually fight and get the authorization for a tachy device. So there is still a little bit of wiggle room over there. And some of these patients have actually had appropriate therapies. So.
I just want to add one more thing. When you look at all the...
No one wants to answer.
No one answers the question.
This is simple. This is fixable.
When you look at all of if you look at all the ICD registry studies, MATA1, MATA2, all of those, there has to be at least a 3% or so risk of sudden death in each year in order to justify really the ICD in those studies. And so I think it depends on your pretest probability before you do the EP study, the VSTIM study. If it's so low that, and Paul Chiari showed that your risk goes up by a factor of 4 if you're inducible. If you start off so low that risk is only going to still be 0.5% after you're done, then there's no real reason to do it in the first place. And conversely, if it's 10% before you do the EP study, then no reason to do it because your risk is only going to decrease to above 3% anyway. So actually, I didn't do the math right, but
yeah.
that's the reason. I think you need to look at the pretest probability.
But more importantly, there's another pathophysiologic point that precisely that the MADIT and the MADIT-2 studies taught us, and that is risk of ventricular arrhythmias with the presence of a scar is time dependent. There are 2 lines of evidence for this. One is if you actually look at intracardiac electrograms, the longer you are from your index infarct, the more wider the local electrograms were, indicating there's a lot of delayed slow conduction. An EGM is nothing but a highly localized ECG for all practical purposes. And the time-dependent risk was very significant because in all these ICD trials, the time for the 2 groups, the treatment versus the control group, it took time for it to diverge. And in fact, they continue to diverge later on. So that's why if someone has not had a shock for 10 years, and when they have a device change out, there are many patients out there who have had their first appropriate shock through their 3rd ICD. So this is year 12 to 15. So that's something to keep in mind. And I think there is no other group of patients in whom this is more pertinent than patients who have had a surgical procedure. So I think that's something that we ought to keep in mind. Again, complete extrapolation of data in the adult literature. But you're never going to have these kinds of studies in these populations.
All right, I'm going to go back to John's question now that everybody's stalled enough for me to look at this EKG. And this is actually kind of a fascinating EKG for a wide complex tachycardia in a TET because it's really neither right nor left bundle branch block pattern, obviously. It is clearly VT, though, because there's a beat sort of in the middle that is pulled early and has a different QRS morphology. That's a fusion beat, so a sinus beat or a atrial beat conducted to the ventricle, that pretty much is diagnostic that this is a ventricular tachycardia. If you look at V6, it's all negative, which is more consistent with a left-sided or apical source than any place else, but you sort of got to go with the odds. It's a TET patient, she's got a ventriculotomy. It's probably related to her ventriculotomy. I'm going to guess she has a very long ventriculotomy, and as a consequence has a very funny looking VT.
It's a very odd axis, isn't it, Kevin?
Yes.
Probably LV base.
Yeah, very unusual axis for a...
So she, where would you guess the exit side is?
What was the history in terms of shunt, and how long did she have a shunt before she had a repair, or just a direct repair?
She had a direct repair at age 20.
Okay, and did she have a palliative shunt before that?
No.
So she had 20 years of cyanosis? Where I'm headed is, we see some people who had their diagnosis made before we had a repair or palliation, 1940. They get their first palliation in 1950. So they went 10 years of cyanosis. Then they get a shunt, then they wait 10 years to repair, so they have volume overload of the left ventricle. It's not uncommon for us to see people with left ventricular origin due to LV dysfunction in that sort of person. And so that doesn't necessarily mean, otherwise you're going to say it's the RV incision, but it doesn't have to be. You know.
No, that's a great
It also
point.
could be around the ventricular septal patch repair, depending on the timing of the surgery.
Sure, where would you say the exit site here is?
No, John, I will get to it in a second. John's point is well taken, because if I didn't know anything about this case, if you didn't give us any history, if you had done like a Perloff physical exam type of thing, you first showed us only the sinus ECG and this ECG, the best diagnosis for this would be ARVC, because this is the type of VTs that you would see in an arrhythmogenic RV cardiomyopathy. This is a very unusual location. It's negative in the inferior leads. You know, it's a VT which is, it's exiting very low, to respond to your question. And this is one of those cases where I would love to see the contrast-enhanced MRI to actually try to answer. So John's question can be answered with that data set. So not everything that looks like, you know, scar or ventriculotomy or some edge of the BSD patch is what we always go in thinking, but I'm sure that we're going to find some of these LVVTs too.
On the other hand, the acute treatment is electrical energy.
Okay, so
She got a cardioversion.
yeah, so let me go back. Well, we did an EP study. So so we induced the VT, and it was actually it looked identical to the clinical VT. There's always going to be some difference in the precordial leads where they're placed in the EP lab versus on the 12 lead. But essentially, what we did a voltage map first, and showed there's an area of scar posteriorly. This is looking sort of from the right atrium into the right ventricle through the tricuspid valve.
Jeremy, you want to just explain the colors of the voltage map? What is?
Yeah. So this is the tricuspid valve here. This is the RV outflow tract, pulmonary artery. And again, a voltage map really just shows the intensity of the electrical activation in sinus rhythm. And so the red is the lowest voltage, and then it sort of progresses through the colors of the rainbow, essentially, out to purple, which is healthy tissue. And that's generally set at 1.5 millivolts. So this is the scar map that we created. And let me just go ahead. Actually, I'll skip. I can get this to play. And this is the RV. So now we're looking at the tricuspid valve here, RV outflow tract. This is sort of an RAO view of the right ventricle. So there's also a scar here in the expected location of a ventriculotomy. This patient actually had a patch. I think Jeanette described the history. It had a patch here and then had a ventriculotomy extended up to the annulus, the most recent surgery. So that's where the scar was. We then did it similar to before. We did entrainment mapping during tachycardia. And the first site is here, site 1. We actually got a pretty nice entrainment map. And in ventricular tachycardia, what we like to see is that the QRS during pacing looks similar to the tachycardia QRS. And we got, and that's called concealed fusion, but we got that from that site, and we also got very good post-pacing intervals from that site, suggesting this is protected isthmus in the circuit. We then looked at other sites in the right ventricle, This is, I'll show the site first. Site number 2 here was a little lower down along the tricuspid valve annulus, sort of basolateral. And again, not as perfect of a sort of QRS match at that site, but the post-pacing intervals were still very good, suggesting we're still in the circuit, but it's outside of the isthmus. And then finally, we looked at some sites out on the free wall of the right ventricle, and these were clearly out of the circuit. And so when we put everything together, this is sort of what we came up with. And this is just sort of a summary slide of where the circuit was going in the heart. Essentially what we found was that, I didn't show all of these before, but we had good post-pacing intervals all the way around the tricuspid valve annulus, with a protected isthmus here, exit site presumably seemed to be here, and outer loop sites, and this all goes back to entrainment principles, but essentially the circuit seemed to be going around the tricuspid valve annulus, whereas sites on the free wall of the right ventricle out here were very remote from the circuit, suggesting that it wasn't going around any ventriculotomy, but it was going around the tricuspid valve annulus. And so that was our presumption at the time of the study, that this is a periannular circuit. And we ended up basically, show you where we ablated. We initially ablated from the ventriculotomy of the tricuspid valve annulus, but we're unable to affect really either the myocardium in that line or the tachycardia. So we ended up doing a line from the pulmonary valve down to the tricuspid valve, and we terminated tachycardia, and actually we demonstrated bidirectional block doing a set of lesions there. And it probably had to do with the fact that there was scar in that area already.
So did you use irrigated RF in this case?
Yeah, we used irrigated.
So that's a point to sort of highlight to our colleagues outside EP. In the early days when we started doing these procedures, Kevin and I had enough gray hair, and I had dealing with the fact that we had these catheters that simply wouldn't make lesions. Sometimes we would infuse saline down sheets, long sheets, to try to cool the catheter tip. Now we have catheters where the actual electrode that delivers RF is cooled. It's actively cooled by internal irrigation and also external irrigation. And that's had a very big impact in the field of VT ablation, macro reentrant tachycardia ablation, because some of these Fontan patients, they don't have much blood flow to cool a catheter tip. So there's been a lot of technical advances, and there are better energy sources that are also in the pipeline, which hopefully will get FDA approval in the next year or so. I think the outcomes of catheter ablation are going to get better in this group of patients.
Yeah. Maybe the yellow dot is the His, or what is that yellow dot?
Yeah, the yellow dot is where we refer to his potential.
No, I think the next slide and then that.
Yeah, so I'll show, this is, I don't know why it's not ring. So this is a paper, 2007 by, it's a combination actually, Boston and Zeppenfeld in Netherlands. But basically this is showing where the potential isthmuses are in Tetralogy of Flow. So it's showing the ventriculotomy or patch in the RV outflow tract, and you can have the first isthmus they described was from there to the tricuspid valve annulus. The second one was from the pulmonary valve to the ventriculotomy, if there was a discrete ventriculotomy. The third from the posterior, this is where we ended up ablating and getting this one, by the way. The third isthmus was from the pulmonary valve down to the VSD patch. We actually went a little bit, we went down to the tricuspid valve annulus next to the VSD patch, but essentially ablated in that isthmus. And then the last one, which they described only a few patients with, was from the VSD patch to the tricuspid valve annulus. And we've talked about this before as far as, is that isthmus even there? It's probably not always there, actually, but it's been described as well. So 4 potential isthmuses. And
if it's there, so is the conduction system.
yeah.
So now, actually, the most challenging decision needs to be made. You've ablated ventricular tachycardia in a woman who may or may not have met ICD criteria when she got her pacemaker. Does she get an ICD?
You put one in.
Anybody opposed? I would agree. I would not count on an ablation to keep someone from dying suddenly because recurrence rate's too high. So with or without an ablation, she earned herself an ICD. And the ablation is really to prevent frequent shocks.
Brian's in the room. there are some centers who are, during surgery, they are doing prophylactic ablation of these isthmi. What do you think about it, and what about?
We don't practice that at all. It's always hard. You know what your head is. You don't know if you'd be effective or not. And ablating that would add quite a bit of time. If you're going to do it effectively, and then especially where the one you're saying for the patch.
You don't want to get the conduction
See,
system.
that is many times that is not even, the isthmus between the pulmonary valve and the VSD, and the one which is hardest for us to do is if there is a ventriculotomy to the anterior aspect of the tricuspid valve, that is the one that is hardest for us. So actually, if you put a cryo probe, and those two lesions are, basically should not, it's easy for me to say that, but it should not take that much of your time.
So what lesion are you talking about? Is the one you're having most?
Number one is the one that's hardest, and I think the other one is number 3. 3 is also relatively safe. It's 4 which is difficult, and sometimes you don't even have an isthmus there.
Yeah, I don't know if anyone who's doing that. I think that would be probably easy to do, but I don't know. Doing a cryoablation thing in a tiny part too is the feel that you're going to get with a cryoablation is scary and hard to inside.
Yep.
So I think you can freeze the whole thing. So it's very hard to control, and that would be difficult. The one going upwards wouldn't be as bad, but I'd be really concerned about the left manual behind that too. So there's a lot of tigers.
But how about a, say, 15, 16-year-old who you're replacing a pulmonary homograft or those?
That need varies.
I think we probably have time for one.
Case number 4 is a 23-year-old woman who presents with atrial flutter. Her congenital cardiac diagnosis is pulmonary atresia with intact ventricular septum. In infancy, she underwent a pulmonary valvotomy and a central shunt. At 4 years of age, she had a homograft and a tricuspid annuloplasty. At 12 years of age, she had another homograft and a redo tricuspid annuloplasty. At 16 years of age, she had a cardiac arrest and an ICD was placed for secondary prevention. Her arrhythmia history continues at age 17 with atrial flutter, for which she underwent an ablation, but at age 18, she had atrial fibrillation, which resulted in 2 ICD therapies, and she also received 2 appropriate therapies for VF as well. She continued to have paroxysmal atrial fibrillation and flutter, and amiodarone had been tried previously but stopped due to issues with thyroid dysfunction. At age 23, she developed progressive severe biventricular dysfunction, as well as at least moderate tricuspid regurgitation, severe pulmonic regurgitation, and along with that, a severely dilated right atrium. She had the atrial flutter, as we discussed, and this is her medication list, which included digoxin, sotalol, diuretics, warfarin, Imdur, hydralazine, lisinopril, and levothyroxine. Let's see if we can. Can you hit play on that slide for me? Or just click on it. Thank you. So this is an apical 4-chamber view focusing on the right side of the heart, the right atrium, right ventricle that you see, and impressive tricuspid regurgitation, as well as associated severe right atrial dilation as well. She had an MRI, which again shows very impressive right atrial dilation. Impressive right atrial dilation, and you see your tricuspid annulus here. This is a EKG of one of her tachycardia events. We would point your attention to the circle.
Thank you, Jeremy.
Showing atrial flutter. Atrial flutter.
Okay, so we basically did what we had done on the other studies. Put up catheters, did activation mapping of the right atrium. This is the right atrium, SVC. This is the coronary sinus. We like to put a catheter on the coronary sinus just for sort of a stable position while we're doing these procedures. But we were impressed by, we mapped out really carefully the tricuspid valve annulus, and these white dots represent signals that were consistent with the annulus. And we were impressed by how small it was relative to the size of the right atrium. This patient had an ICD lead placed across the tricuspid valve previously, and at least moderate to severe, really, tricuspid regurgitation related to that. But the circuit itself was consistent with a counterclockwise isthmus-dependent flutter, similar to what we had seen. Is one of the more common tachycardias that we see. This is just showing the septal surface of the right atrium, showing activation proceeding superiorly. And we found pretty good entrainment sites down at the typical isthmus, which was consistent with that mechanism also. We didn't see a second circuit in the free wall in this case. But basically, we placed lesions connecting the tricuspid valve to the IVC, and we saw slowing, and almost immediately, actually, this patient had a prior ablation down in this area, actually, but still, it looked like she had basically a gap in the prior ablation site. So we, with the fourth lesion, we saw slowing and then termination of the tachycardia. That's just showing where the ablation lesions were placed. These are the red dots from ablation. We also then verified that there's block in that site, so that there wasn't conduction through here in either direction. And this is actually, this map actually is pacing from the coronary sinus and mapping activation going around the tricuspid valve and then ending up latest on the other side of where we had placed those lesions, suggesting that there was no conduction going through this direction. We did similar studies to show that with the electrograms, basically pacing a little bit lateral to the ablation line and then closer to the ablation line, and showing that there is increasing times to the ablation catheter from the CS. That's basically it, but we were mostly impressed by the regurgitation and the size of the right atrium, despite 2 prior tricuspid valve annuloplasties in this patient. And so I think talking about leads and ICDs and things is probably reasonable in this situation.
Yeah, actually, I think this does bring up a very important point, and someone asked me about it in the break, but putting leads across a tricuspid valve we think of as being very benign, but in this case probably led to a lot of problems, because it probably created some degree of tricuspid stenosis, especially this is presumably a more active 20-year-old woman. She probably increases her cardiac output, and that narrowed tricuspid valve becomes a lot worse. Add to that that's an ICD lead, which is a lot less flexible than a pacemaker, and it's probably holding that tricuspid valve open, and from the echo, that tear jet starts very low in the ventricle. I would guess that ICD is, that the coil part of that ICD lead is actually scarred to of a tricuspid valve leaflet and tethering it down inside the ventricle, and that's why it looks like that. And so, I think this is a case where probably putting in the ICD, it did say she had 2 appropriate shocks. Mm-hmm. So, good thing she had it, but it probably caused a fair amount of harm.
But this is somebody with the original diagnosis of pulmonary atresia in that particular step.
With an abnormal tricuspid valve to begin with.
With an abnormal tricuspid valve to begin with. So frankly, even in the absence of any tricuspid stenosis, the right atrium is, because of the restricted physiology of that right ventricle, is going to be huge. But I agree, the mechanism of tricuspid regurgitation is certainly not annular dilation. It appears to start lower down, which suggests that it is the ICD. But in truth, is there anything that we're going to do hemodynamically here outside of diuresing, decreasing the volume, and sort of bringing her down on that pressure volume curve in a very non-compliant RV that is going to really change anything here? It's in a way you have to put on an ICD, right, for this kind of thing. If you were just to correct the hemodynamic problems that this patient has, do you think that would have been enough? Very unlikely.
No, I agree. I think, and obviously she had 2 appropriate shocks, so I think it would have been a really bad idea not to have had the ICD, because then we wouldn't be talking about her tricuspid valve stenosis.
Well, I guess what that's leading to is, at the time that she had her last tricuspid valve annuloplasty, you have an issue with the tricuspid valve and somebody who needs protection, whether some sort of epicardial system could have been put in to allow, to protect that tricuspid valve long term. Does it matter you know, and is the effectiveness of an epicardial system, you know, a major issue here?
You know, one issue is, the commonest mistake sometimes people make is when you're putting in the RV lead, especially if it's slightly difficult, then if it just even goes across straight, they just take it. So is it possible it's gone through the chordae and is, you know, holding it down, don't know. So again, one of the golden rules is always prolapse and go across the RVOT. So this way, I don't know whether there's any way to prove it or not, but can't rule that out.
Couldn't agree more. And there's data in non-congenital patients, and Mayo Clinic has published several series on this, where, and the original paper came from Andy Epstein, where we completely destroy the tricuspid valve when it's not done carefully. So there are small things that, you know, expert centers always do, but people just say it's sticking in a pacemaker or an ICD, where congenital patients perhaps are best, you know, left to undergo implants by teams that are used to this type of an anatomy. And who knows, one approach may be to use something like 3D TEEs. You know, things like that may actually help, you know, a better trajectory to get into the ventricle. We don't have data just yet, but another thing that you can consider in some of these patients is to actually use an LV vein. And we actually have experience, not in congenital patients, but in other patients where we actually placed LV shock leads into a coronary vein that's in the LV, and that actually tends to be good for defibrillation in a way. And now we have better lead systems for even sensing ventricular activity from those leads. So there are approaches where you don't have to necessarily cross a tricuspid valve, but it's not there just quite yet, but you have to case by case pick them.
So Shiv, if there was a similar, it's just a follow-up, if there was a similar situation like this with a bad tricuspid valve, would you consider putting an azygous coil and testing and making, if that works, would you leave it at that?
So there's a bit of a leading question. Many years ago, we looked at patients who are very difficult to defibrillate, and just because of the fact that we had such a close interaction with the congenital team, and we actually knew where the azygous vein was in the human body, we actually used a shock lead down the azygous vein, and that gives you a very good vector for defibrillation, especially if you have to put in a right-sided device. So the answer is yes. And you're far better off just putting a rate sense lead down the RV. So what Kevin Shannon just pointed out, you don't have a bulky, heavy lead that's going across the tricuspid valve. I mean, this is where it gets to be very interesting, you know, the back and forth discussion and picking the right hardware when you're forced to actually leave hardware in.
Do you foresee in a population that gets so many operations a role for prophylactic epicardial ICD multi-site pacing systems that would be placed in a woman like this when she undergoes her second or third operation, so that, you know, we don't even need to go through these other intravascular steps and you know, what has been an issue, at least to the non-electrophysiologist, has been the lower efficacy of epicardial ICD systems and the difficulty of placing them.
True.
But do you think we're entering an era now where we can sort of change that paradigm?
So the answer to that is absolutely, and perhaps we should convince the Ahmansons to give us a $50 million endowment to develop these technologies, because, you know, it's very sad. What's happened is, you know, the device industry has made a lot of money in adult cardiology in the post-infarct, you know, made-it type patients. And the entire epicardial systems have had an arrested development. So there are now pacing leads that have better outcomes, better long-term data. But there's been almost like sort of it's atrophied, that entire area of medical technology development. So hopefully, you know, that's going to require the next wave of creating new med tech that can address these questions. And the answer is yes, we can and we should do this, because current epicardial systems have the worst data out there, and especially defibrillation patches. It's causing an iatrogenic disease. It actually causes a form of severe constriction. To begin with, you're dealing with complex hemodynamics, and God forbid if any of those systems get infected, it's like operating on constrictive pericarditis, and Brian Reamston wouldn't return your calls. So.
Just one quick comment about the epicardial ICD is certainly an option for someone like this if they present with a need for an ICD and don't need any kind of pacing. That technology is now approved in the United States. It's a much larger device. Sub-Q, not epicardial, right? So it's actually relatively easy to insert, but it's a very large device in your axilla with a lead that crosses to your midline and then runs up your sternum under the skin, not intrathoracic. And the data on that is that the safety and efficacy is every bit as good as the transvenous systems, and it avoids intrathoracic hardware altogether. I'm not sure, there's not enough data to really know what the real long-term inappropriate shock rate's going to be, or sort of the lead recall problem is going to be, but it looks very promising, and I think that would have been an option for this woman. The other option is along the lines of what Shiv said. You can put in a coronary sinus pace sense lead if you need pacing, and you can actually do something similar with a subcutaneous coil that goes around the back for your shocking vector and avoid crossing the tricuspid valve with any hardware. And that would have been something, had this person gotten an ICD in a more recent era, that we would have done probably to avoid crossing what is already a known to be abnormal tricuspid valve with some stenosis, with significant chance of regurgitation. And so I think in the modern era, we have lots of different tools to avoid doing damage to a tricuspid valve, particularly one as at risk as a pulmonary atresia intact septum.
There is a 4 French lead which is actually now it's not available, right? The
Yes.
Select Secure, there's a 4 French Medtronic lead, but apparently there was an FDA issue with the steroid on the coil, so that's one option which we had. If you had to go, you could put a 4 French rate sense lead, and in fact it goes through a sheath, so you can actually better control where you're going to place it. Unfortunately, not available now.
I think the point made by Kevin Shannon about sub-Q ICD is it's a Cameron Health device acquired by Boston Scientific. That particular device should be kept in mind in patients who have a central shunt. So if you had a univentricular heart or that type of physiology where you simply do not want a endovascular lead at all, it's worth keeping in mind. And in fact, it'll be the one classic indication for it. So.
Yeah, I think the 3 lesions we see where we wish we could put in an ICD but we're afraid to are Eisenmengers, because we know they're very high risk, and if you have a very functional Eisenmengers with ventricular arrhythmias without need for pacing, that would be an option for them, as long as they're not in that category of not likely to survive another year. I think that's a class 3 indication for an ICD, meaning you shouldn't do it if you're not going to survive for a year. The univentricular hearts. Another group of patients where we don't want transvenous hardware. We'd rather avoid doing a thoracotomy and placing epicardial systems because of the potential need for transplant in the future. And then any of the cyanotics, anyone with a obligate right to left shunt, even if they don't have pulmonary hypertension, they can all get epicardial systems as long as they don't need pacing. And I think we're going to start seeing the adult congenital population that fit in those categories get these more frequently. I think on that note.